Greetings to everyone interested in this review paper. The paper is trying to address the question why AC2 targeting coronaviruses produce a higher mortality rates in elderly or hypertensive patients. This paper is based on reports that if some patient is older or have hypertension of other comorbidities, the risk of death outcome is higher. It was increased both in the first epidemics in 2003 and also in the current epidemics of COVID-19. There are two questions. One is it possible that for some reason lungs and heart muscles are more vulnerable to reduced AC2 activities in older or hypertensive patients? And the second is whether are other organs in the similar position, which is potentially important for the late outcome of COVID-19. To address this question, I have used the available data of RNA gene expression in human tissue samples that are available at biogps.org. I have used expectation maximization clustering of their data for 12 renin-angiotensin system-related genes, and also for 60 tissue samples of tissues important in circulation. Here is an example of original data set. This is for the prorenin receptor, and you can see how this data look in the database. Two things have been found. If we are looking at the vasoconstrictive arm of the renin-angiotensin system, then the expression of AC and vasoconstrictive angiotensin type 1 receptor clustered only with the prorenin receptor, and this simple combination of three genes were highly expressed in cardiac myocytes, in adipocytes, in adrenal gland, and in lung. If we are looking at the vasodilatory arm of the renin-angiotensin system, it is much more complex. AC2 clustered with the MES1 receptor, also with the prorenin receptor, with renin expression, with renin binding protein, with AC, with angiotensin type 2 receptor, with endothelin 1, and with both endothelin receptors, and also with thrombospondin 1. This setting were highly expressed in liver, in cardiac myocytes, in skeletal muscle, in uterus, in kidneys, in lungs, in small intestine, and also in smooth muscle. Here you can see a graph showing a distinction between two clusters of expression of vasoconstrictive genes. And here is the second setting for the vasodilatory genes, and you can see that both clusters separated very well. This table shows distribution of tissue samples. Based on these findings, an interpretation is proposed that we have two arms of the renin-angiotensin system, the systemic resistance arm and the tissue perfusion arms, and they are both dependent on the prorenin receptors that bind both renin and prorenin. To link it with older age and comorbidities, we have to introduce the problem of stress accumulation. The main argument is that prorenin in blood is of very little or no activity until it binds to its receptor. On the other hand, renin in circulation is active, but it can enhance its activity several times if it is bound also to the prorenin receptor. And this means that in individuals with chronically increased renin secretion, this binding to prorenin receptor can increase the overall capacity for producing angiotensin 1. And this can lead to arterial hypertension, increased vascular resistance, condition that is often found in older or in highly stressed individuals. If you're looking at the effects of coronavirus infection in these individuals, uh, reducing activity of AC2 due to corona infection can lead to reduced tissue perfusion that will slowly exhaust the cardiopulmonary reserve in this patient. And this can be the key mechanism of cardiorespiratory failure. Beside that, this paper is also focused on the topological hierarchy in our circulation that allows the mediators to act only on downstream tissues. We can conclude that this paper proposes that the expression of pro-renin receptor and renin exposure can alter pressures along the arterial tree in many older or stressed individuals. It will change systemic vascular resistance and thus worsen the cause of coronavirus infection. I wish to thank you on your time.